Welcome back to the Great Adventure, Pediatric Pulmonary Physiology. This is the 28th presentation in a series of 30, and today we're going to continue to talk about high altitude physiology. This is the second part of that series. So this is the Great Adventure, Pediatric Pulmonary Physiology. As mentioned, session 28 out of 30. We want to approach this with the enthusiasm of a child in a candy shop. And today we're going to talk about control of breathing at high altitude, the hypoxic ventilatory response and maximal exercise at high altitude, and some aspects of non-pulmonary acclimatization to high altitude. A reminder that most physiologic studies measure altitude in meters. Most of us are familiar with altitude measured in feet. To convert meters to feet, basically we can approximate this by 1 meter equals 3.3 feet. So multiply meters by 3.3 and you'll have an approximation of the altitude in feet. So control breathing at high altitude. So we talked last time about the difference between acclimatization and adaptation. And you can see that the ventilatory response to CO2 actually increases after a day or so into several days, among other things. So of all the changes in acclimatization to high altitude, those increasing ventilation are the most important. So we've talked about control of breathing in the past. Remember that all neurologic processes have a sensor, an integrator, and a motor response. If we look at the hypoxic ventilatory response, we're talking primarily about peripheral chemoreceptors, which when stimulated input into a ventilatory controller, and the output of that, of course, is minute ventilation. So the hypoxic ventilatory response, when minute ventilation is plotted against falling PO2, it's an exponential response. So there's not much that happens before you get down to a PO2 of 60, but after that, ventilation increases exponentially. With respect to O2 saturation, there's actually a linear relationship with minute ventilation and O2 saturation. And as saturation falls, minute ventilation increases linearly. Basically, hypoxia stimulates ventilation below about a PO2 of 50. That's linearly as O2 saturation falls. And this, of course, preserves both saturation and arterial oxygen contact, that is the increase in ventilation in response to hypoxia. So let's look at the time course of the hypoxic ventilatory response when ascending to altitude. So up to about 10 minutes, there's an initial acute increase in minute ventilation and decrease in arterial CO2. About 10 to 30 minutes, this is followed by a hypoxic ventilatory decline. This actually has decreased ventilation, increased CO2, and is back towards the pre-hypoxia levels. Not quite, but toward. 30 minutes to 2 weeks, there's a respiratory acclimatization, which increases minute ventilation, decreases in arterial CO2, and this continues up to about 2 weeks when both hypoxic and hypercapnic ventilatory responses increase. So this is PCO2, either alveolar or arterial. So acutely ongoing, if this is the sea level value, on going to elevation, there is a drop in CO2. Then there's this hypoxic ventilatory decline, right? So CO2 comes back up, but not quite to sea level values. And then over the course of several days to 2 weeks or so, gradually continues to decrease, which of course increases oxygenation. And then if you return to normoxic, then CO2 comes back to normal. When acclimatized individuals return to sea level PO2 after being exposed at altitude acutely, there's a decrease in ventilation, increase in CO2, not quite back to sea level values. So as I mentioned, there's a ventilatory deacclimatization from hypoxia. So the increased partial pressure inspired oxygen turns off the hypoxic ventilatory response. Remember, if you're above a PO2 of 60, there's not much ventilatory response to hypoxia. The residual increased minute ventilation is due to a continued increased hypercapnic ventilatory response, which is induced by the acclimatization. And the time course of the ventilatory deacclimatization from hypoxia is similar to acclimatization. So this plots both alveolar PO2 and alveolar PCO2. So what you can see in the individuals who are acutely exposed to hypoxia is PCO2 doesn't change much until you get down below this PO2 of 60. Remember, that's the threshold. And then PCO2 drops dramatically due to the hypoxic ventilatory response. Now, subjects who are acclimatized, note, have a more continuous drop in PCO2 with a drop in alveolar PO2. So that's really a difference between those acutely exposed and those who are acclimatized or chronically exposed. They're able to fine tune their PCO2 a bit better than those who are only acutely exposed. This shows ventilation in exercise. So what you see here is that this is ventilation in response to oxygen uptake exercise at altitude, and then with acute hyperoxia following altitude. So obviously at altitude, the minute ventilation is increased at any level of O2 consumption. If we acutely make someone hyperoxic after being exposed to altitude, it decreases back toward the sea level value, but not quite completely. And this difference, remember, is due to the still increased hypercapnic ventilatory response from acclimatization. Ventilatory deacclimatization to hypoxia results in a decreased ventilation of only about 40 to 50% of the change to sea level. Thus, in acclimatized individuals, about half of the increased ventilation to altitude is due to the hypoxic ventilatory response, and half is due to the hypercapnic ventilatory response. And again, the time course of ventilatory deacclimatization to hypoxia is similar to that of acclimatization. An important aspect of respiratory acclimatization to high altitude is the increase in the hypercapnic ventilatory response, and this increases progressively over the first 3 weeks or so at altitude. We talked about the hypoxic ventilatory response. The hypercapnic ventilatory response, of course, uses central chemoreceptors, which stimulate the ventilatory controller and increase minute ventilation as the mode of response. This is the normal hypercapnic ventilatory response, and you can see there's a tight linear correlation between increase in minute ventilation and increased PCO2. An increased ventilatory response would be a steeper line, a decreased ventilatory response would be a shallower line. And here you can see the ventilatory responses to hypercapnia in an individual initially at sea level. Okay, so PCO2 down here, ventilation, and days at altitude. So as this individual stays at altitude longer, this curve, one, the slope steepens, but secondly, the takeoff or the start of the increase of ventilation actually falls. So a normal individual wouldn't have much of a response at a PCO2 of 40, for example, but certainly by the time one has been at altitude for 3 weeks, 20 days, there's a significant ventilatory response at a PCO2 of 40, as you can see here. So both the slope and the position of the hypercapnic ventilatory response change, that is, increase ventilation with altitude. So central chemoreceptors, of course, are located in the medulla of the brainstem. They respond to hydrogen ion changes in cerebral spinal fluid. CO2 diffuses readily across into the CSF across the blood-brain barrier, which causes that increase in hydrogen ion by this equation, which stimulates chemoreceptors, as you can see. So this responds to acute changes in PCO2. It's very sensitive, and it's responsible for fine-tuning of breathing minute to minute at sea level. Central chemoreceptors are reset with acclimatization to increased ventilation. So with chronic hyperventilation, renal excretion of bicarb increases. Thus, the serum bicarb and the CSF bicarb decrease. And the decreased CSF bicarb in central chemoreceptors increases minute ventilation. That is, the CSF is more acidic. So what we see here is minute ventilation, PCO2, okay, and cerebral spinal fluid hydrogen ion concentration. So what you can see is that in individuals with a higher CSF bicarb, minute ventilation will increase as PCO2 increases, according to this line. But if we have decreased bicarb in cerebral spinal fluid, Then one, the takeoff point, the point where ventilation starts to increase, is at a lower PCO2, and the slope of the line is slightly greater. So more decreased CSF bicarb or more CSF hydrogen ion concentration increase both the slope and improve the position of the hypercapnic ventilatory response. So lowlanders going to 3,800 meters, so we're talking about 14,000 feet or so, CSF bicarb in the central chemoreceptors drops from about 25 to about 20 on day one, and a little bit lower on day 8. Residents at high altitude, that is long-term residents, have a similar CSF bicarb that is about 19 to 21. So it's similar to what lowlanders do to adapt within the first week. Thus, decreased CSF bicarb resets central chemoreceptors and increases the hypercapnic ventilatory response to acclimatize to high altitude. Of all the physiologic changes in acclimatization to high altitude, those increasing ventilation are the most important. Hypoxic and hypercapnic ventilatory responses both increase in the first few weeks of life, and hypoxic ventilatory response is most important to assure increased ventilation at high altitude. The hypercapnic ventilatory response also increases, and as mentioned, about 50% of the increase is due to each of those two responses. So let's look at hypoxic ventilatory responses and maximal exercise at high altitude. So the hypoxic ventilatory response is an inborn characteristic that varies between individuals, probably to some extent genetically determined. The purpose is to maximize the chance of survival in a perilous environment. So adequate minute ventilation is necessary to maintain sufficient alveolar and arterial PO2 at high altitude. For healthy individuals at sea level, ventilation is easy and is mediated by arterial PCO2. However, it plays an integral role, that is the hypoxic ventilatory response, in survival at high altitude where PO2 can be precariously low. At sea level, peripheral chemoreceptors are not responsible for breathing minute to minute. They only stimulate breathing when arterial O2 is less than 60, and they primarily provide backup when central chemoreceptors fail. So this is the hypoxic ventilatory response plotted against PO2, and so an increased ventilatory response would be a movement of this line up, a little bit steeper. A decreased response would be a movement of the line down. And again, minute ventilation versus saturation, an increased response would be a steeper line, a decreased response would be a more flatter line. So what about endurance exercise at sea level? So it turns out the ventilatory equivalent for CO2, that is, the number of liters you need to breathe to produce a liter of CO2, correlates with hypoxic and hypercapnic ventilatory responses during exercise. And this just shows this. What's plotted on the y-axis is the ventilatory equivalent for CO2, VE over VCO2. And at light, heavy, and maximal exercise, you can see that the greater somebody's hypoxic ventilatory response, the greater the ventilatory equivalent for oxygen. And similarly, the greater one's hypercapnic ventilatory response, the greater the ventilatory equivalent for CO2. During light exercise, the ventilatory equivalent for CO2 plotted here and PCO2 plotted here. So if one has a higher ventilatory equivalent for CO2, that tends to correlate with a lower PCO2. That is, you're breathing more to produce a liter of CO2, so the PCO2 is actually going to be lower. An increased hypoxic ventilatory response decreases the alveolar CO2, which increases alveolar O2. But not all inspired oxygen is consumed. So at sea level, there's plenty of reserve alveolar oxygen so that one does not need to increase ventilation to preserve alveolar O2 and meet metabolic demands. So the increased hypoxic ventilatory response also increases minute ventilation, work of breathing, and a feeling of dyspnea, like you've got to breathe. So a decreased hypoxic ventilatory response might be better for athletes because of decreased perceived dyspnea, which might enhance performance. So at sea level, a hypoxic ventilatory response is not necessary. And in fact, when this has been measured in non-athletes, if this is the ventilatory response or the ventilatory equivalent for CO2, which remember correlates with ventilatory responses. And now we're going to decreasing P alveolar O2, right? So not much happens till you get to about 100, and then it increases. But note, non-endurance athletes, and especially endurance athletes, actually have a lower ventilatory response than non-athletes, right? And again, the reason possibly is if they're exercising at sea level, they don't need a hypoxic ventilatory response. And in fact, by increasing ventilation or by them feeling like they really need to increase ventilation, they may in fact have a perception of dyspnea, which might limit their performance. How about endurance exercise at high altitude? So, interestingly, in 1978, Peter Haberler and Reinhold Messner both climbed Mount Everest without supplemental oxygen. So, how can they do this? Adequate ventilation is necessary to maintain sufficient alveolar and arterial PO2 for tissue oxygenation. The hypoxic stimulus during high altitude exposure increases minute ventilation. Renal compensation for respiratory alkalosis over days increases minute ventilation further. So oxygenation falls with increasing exercise, remember. Thus, tissue delivery of oxygen to exercising muscle is limited by oxygen transfer to the circulation. Hyperventilation increases PO2, so an increased hypoxic ventilatory response may be beneficial because it increases critically low alveolar PO2. This is for endurance exercise at high altitude. And here what we have is the ventilatory equivalent for oxygen, right, which also correlates with the hypoxic ventilatory response versus exercise here, and this is workload. And you can see at sea level, there's not much change. But at high altitude, first of all, the amount of exercise one can perform is considerably less. But there is much greater ventilation, liters per liter per minute of oxygen consumption at high altitude. So the ventilatory response here becomes critically important. And this is at a barometric pressure of 350. So we're getting up close to the top of Mount Everest. And this is the ventilatory responses. So in controls in the green, this is their curve. Runners, that is, successful runners at sea level, as mentioned, have a decreased ventilatory response. But climbers, like Haberler and Messner, free climbers of Mount Everest, actually have an augmented ventilatory response. So they need this to be able to free climb Everest because the increased ventilatory response decreases CO2 more and therefore increases alveolar O2. This just shows the fall in oxygen saturation. Fall in oxygen saturation from rest to maximal exercise in people with a low ventilatory response to hypoxia versus a high ventilatory response. So high ventilatory response, there's not as much fall as in somebody who doesn't mount a significant hypoxic ventilatory response. So hypoxic ventilatory response is increased in successful high altitude climbers. So at high altitude, there's no reserve alveolar oxygen, so the one needs to decrease CO2 to preserve PO2 and meet metabolic demands. In contrast to sea level athletes, high altitude climbers benefit from an increased hypoxic ventilatory response because it decreases CO2 more, which increases alveolar PO2 even more. And that's just diagrammed here. If this is a normal situation, if one hyperventilates, decreases CO2, then there's more oxygen in the alveolus. Decreased hypoxic ventilatory responses at altitude are associated with high altitude pulmonary edema, acute mountain sickness, and chronic mountain sickness. So acetazolamide is commonly used to treat mountain sickness. It's a carbonic anhydrase inhibitor, so it increases dissolved CO2. That is, carbonic anhydrase basically catalyzes the reaction of oxygen plus CO2 to carbonic acid. If you block that, then you have more dissolved CO2, that is, higher PCO2. And this therefore increases minute ventilation and the hypoxic ventilatory response and improves saturation during sleep, acute mountain illness, and chronic mountain sickness. The hypoxic ventilatory response correlates with the response after acclimatization to altitude. So hypoxic ventilatory response predicts exercise ventilation at sea level and at altitude. Hypoxic ventilatory response protects saturation during exercise at altitude and it may predict adaptation and performance at extreme altitude. A high hypoxic ventilatory response appears to be necessary for climbers to extreme altitude without supplemental oxygen. Let's talk about non-pulmonary acclimatization to high altitude. So the cardiac response. So cardiac output increases following acute exposure to hypoxia. Cardiac output is the same as the sea level response for acclimatized lowlanders and highlanders. Show that in a second. Because of polycythemia, hemoglobin flow is increased. Heart rate increases transiently and stroke volume falls. Systemic blood pressure remains at sea level values, but may have a transient increase. And there are few cardiac arrhythmias in normal individuals. So this just shows a number of things here. So we have cardiac output versus work rate, and what we have is sea level in the closed circles and high altitude, about 20,000 feet in the X's. And you can see that the response of cardiac output to work rate is about the same. At high altitude, they don't go to as high a level of work, but where they do, it's about the same. Cardiac output over oxygen intake is about the same. This is cardiac output versus heart rate. So except that lower heart rates here, they end up being about the same. And this is the AVO2 difference. And you can see that this does start to fall on altitude compared to at sea level. This plots cardiac output again against work. And in this case, we have individuals at three levels of altitude, barometric pressures here. This is slightly higher than Mount Everest, actually. So you can see that, again, the responses are the same as far as they go. Cardiac output versus VO2 stroke volume versus VO2 does tend to be a little higher at sea level. It's a little less at altitude. And stroke volume versus heart rate, again, is higher at sea level and less at altitude. Pulmonary hypertension can occur at high altitude, and it occurs at high altitude in newcomers, acclimatized individuals, and highlanders. It's only relieved by supplemental oxygen after acute hypoxia. And even after a few days, pulmonary hypertension from chronic hypoxia is not reversible with oxygen. Remodeling of the pulmonary vasculature does occur, and right ventricular hypertrophy is common, especially in high altitude residents. So what's shown here is cardiac output on this axis and the pulmonary vascular pressure gradient. All right. So this is basically arterial pulmonary pressure from the pulmonary artery to wedge pressure. And you can see here that at sea level, there's not much change in pulmonary artery pressure with change in cardiac output. But as you get to altitude, there becomes a significant change with increased pulmonary artery pressure with increased altitude. This can be treated with sildenafil, which is a vasodilator. And what you can see here is 6 days at 14,000 feet, all right, 4,300 meters, all right, and you can see that what's plotted is heart rate versus days at this altitude. And you can see that it's slightly lower in the sildenafil treated patients when they're at altitude. The oxygen saturation is slightly higher in the sildenafil treated patients when they're at altitude. Blood pressure doesn't really seem to change that much. This is systemic blood pressure. And the decrease in maximal O2 consumption, you can see here, is less with those who are treated with sildenafil. This all suggesting that increased pulmonary artery pressures contribute to some of the limitations at exercise. This shows resting pulmonary artery pressure in three groups here. So we have North American individuals who are not acclimatized, okay, and we're decreasing PO2 here. High Andes acclimatized individuals in South America and Tibetans acclimatized here. We'll talk later about why this might be the case, but part of the reason is that inhabitants of Tibet have been there for about 30,000 years. So one could argue, or one could conceive, that genetic differences, that is adaptation occurring over centuries, has influenced this entire population. In South America, they haven't been in the Andes quite as long, more like 12,000 years, and presumably the amount of genetic adaptation has not occurred. Acute hypoxia has a number of cardiovascular effects. So obviously it causes pulmonary vasoconstriction, which can predispose to pulmonary hypertension. It does cause systemic vasodilatation, and this results with exercise at least, an increase in blood pressure, heart rate, cardiac output occurring there. Sympathetic activation is also increased with hypoxia from peripheral chemoreceptor. Cold and exercise also cause sympathetic innervation, which do this with peripheral chemoreceptors, increased ventilation, decreased PCO2, increased pH, which help to inhibit the pulmonary hypertension shown here. Hemoglobin. The best known feature of altitude acclimatization is an increase in hemoglobin. The increase in hemoglobin is initially due to decreased plasma volume. This is followed by an increase in red cell mass. Hypoxia increases erythropoietin, which increases hemoglobin. Erythropoietin is increased by a decrease in saturation, not by PaO2. Therefore, blood oxygen content is preserved, and it equals oftentimes sea level value. And this is just shown here. Individuals who start at sea level go to 4,000 to 5,800 meters, so we're 16,000 feet or so, 19 weeks, 20, 22 weeks, and about 39 weeks. And you can see that what happens is hemoglobin increases. This is initially due to a decrease in plasma volume, which actually stays a bit lower than blood volume, but the red cell mass ultimately increases as well. The initial hemoglobin increase, however, that occurs abruptly is actually due more to a decrease in blood volume than an increase in red cell mass. So this just gives you an idea of what's going on. At sea level, we have a hemoglobin of 14.5 grams per deciliter, a saturation of 96%, and the oxygen content is about 18.9 mLs of oxygen per deciliter. Oxygen carrying capacity then is about 20. For 5,800 meters, which is 18,000 feet, the saturation is only 75%, but the hemoglobin is much greater. So it turns out the oxygen content is about the same, 18.9. So basically, one protects or preserves oxygen content even with a falling saturation by increasing hemoglobin. The increase in hemoglobin is proportional to altitude, and it's similar in acclimatized lowlanders and highlanders. A hemoglobin of greater than 22 grams per deciliter in high-altitude residents is considered pathologic, and it is associated with chronic mountain sickness, which we'll talk about down the road. High hemoglobin increases viscosity, which decreases cardiac output and oxygen delivery, and an optimum hemoglobin at altitude at this point in time is actually not known. This shows hemoglobin plotted against altitude in a number of high-altitude residents. So Chinese in Tibet, and they're shown here. Colorado mining town, so Leadville. Their thing is right along here. South India high hills, so the foothills, if you will, of the Himalayas, right here. Residents of the Andes, or the squares shown here. Nepal Sherpas are the triangles, and again, they have a bit lower hemoglobin per altitude, which is an adaptation. And then climbers after 3 months at altitude are shown up here. There, perhaps a little bit of adaptation. And the Tibetans here, note, are significantly decreased. Again, an adaptation, presumably over 30,000 years or so. Their hemoglobin is not quite so high, which we'll see down the road is, in fact, in this case, beneficial. This is the effect of hematocrit on viscosity of blood. So water has a viscosity of 1, plasma slightly higher, and then blood increases dramatically as hematocrit increases. So it basically has a viscosity about 4 times normal with a normal hematocrit of 40, but this can increase to up to 10 times normal at high hematocrits of 70. Blood boosting, that is increasing hemoglobin at sea level, is associated with increased endurance athletic performance. Blood boosting at high altitude, however, does not seem to increase athletic performance, and the reasons may be diffusion limitation of oxygen transport and the increasing viscosity, which decreases cardiac output and therefore decreases O2 tissue delivery. Altering oxygen affinity for hemoglobin does affect oxygen transport. So hyperventilation moves the oxyhemoglobin association group to the left, increasing the O2 affinity of hemoglobin. Acclimatized lowlanders and highland residents have respiratory alkalosis not completely compensated. Metabolic compensation is slow due to chronic volume depletion. So if this is the oxyhemoglobin dissociation curve, P50 marks the PO2 at which hemoglobin is 50% saturated. You get an increased affinity for oxygen, that is, a higher saturation for the same PO2 with decreased temperature, alkalosis, and decreased PCO2. Note, however, that this does decrease O2 tissue delivery. Decreased O2 affinity for oxygen, which is actually associated with increased tissue delivery, is caused by increased temperature, acidosis, increased PCO2, and increased 2,3-DPG in red cells. So these are studies by Barcroft from the early 20th century, which tried to give some idea of the magnitude of the shift of the oxyhemoglobin dissociation curve, which tried to give an estimate of the magnitude of the shift in the oxyhemoglobin dissociation curve that is caused by PCO2, pH, and temperature. And you can see here that the changes due to temperature seem to be greater than with PCO2 or pH. With altitude, P arterial O2 is decreased. PCO2 decreases with altitude, which increases the arterial PO2, relatively speaking, the same PO2. 2,3-DPG decreases hemoglobin affinity for oxygen, and this increases with altitude. However, an increased pH will again increase oxygen affinity for hemoglobin. And a decrease in P50 is a left shift in the O2 oxyhemoglobin dissociation curve, so that oxygen saturation is preserved at high altitude. O2 diffusion in tissues. We haven't really thought about this. We've thought about O2 diffusion in the lungs. But oxygen needs to diffuse from blood to peripheral tissues. So the tissue capillary presumably has a PO2 that's equal to mixed venous, that is about 40 torr. PO2 in the mitochondria is estimated to be about 1 torr. The diffusion distance from the capillary to the mitochondria is about 50 microns. So limitation of diffusion is primarily in the capillary wall. So thus a large diffusion gradient is required to move oxygen from the capillary across the tissue capillary wall into the mitochondria. What helps this out is myoglobin. So hemoglobin has a P50 of about 27 torr. That is, at 27 torr, hemoglobin is 50% saturated. Myoglobin has a P50 of about 3, so that a PO2 of 3, myoglobin is 50% saturated. So therefore, myoglobin in the cell can pick up a lot more oxygen, even at very low PO2s, to help transport this oxygen from the blood to the mitochondria. It's very clever, actually. Myoglobin with a very low P50 basically sops up oxygen, even at a very low PO2, and this can transport that into the mitochondria for energy production. So myoglobin has a lower P50, thus higher oxygen affinity. This increased O2 content at low PO2 increases basically O2 content at low PO2 and increases O2 diffusion. Capillary density is also increased at high altitude due to decreased muscle fibrous size, not increased capillaries. So the capillary density in this case is not necessarily a positive adaptation. It's due to decreased fibrous size. And oxidative enzymes are increased at moderate altitude, but actually decreased at extreme altitude. Myoglobin really facilitates the diffusion of oxygen from systemic capillaries into the mitochondria. Nutrition and metabolism. So loss of appetite and weight loss are common at high altitude. Below about 4,500 meters, appetite returns after a few days, but anorexia persists at higher elevations. So basal metabolic rate is about 10 to 17% higher at 4,000 to 6,000 meters. That's 13,000 to 20,000 feet. And it may be greater at higher elevations. Weight loss of fat is greater than that of muscle, but intestinal malabsorption probably does not occur. A high carbohydrate, low fat diet is preferred by most climbers at high altitude. Part of the reason probably is that taste is dulled by hypoxia, which may contribute to the anorexia. So John Scott Haldane, a pioneering um, respiratory and exercise physiologist, said about one of his expeditions, one must climb several thousand feet over snow and ice. The climate is Arctic, even in midsummer. Worst of all, the investigator must cook for himself, open to question whether the effects observed were due to barometric pressure or to bad cooking. So if fat is metabolized, the RQ is 0.7. If carbohydrates are metabolized, the RQ is 1. With a higher RQ, all right, now follow me with this. With a higher RQ, there is less O2 consumption per CO2 production, increasing the PO2, right? Thus, for any given PCO2, the PaO2 is increased. So high carbohydrate diet may improve PO2 by decreasing PCO2. And that's shown here. So what we've plotted is PO2 on this axis, PCO2 on this axis. All right, so if you have a PCO2 and an RQ of 0.7, you have a PCO2 which will decrease the PO2. On the other hand, with an RQ of 1, even if the PCO2 remains constant, the PO2 is relatively increased because of just the difference in metabolism. And these are at 1500 meters elevation. So a high-fat diet, again, would be an alveolus like this. High carbohydrate diet, you actually have increased O2, decreased CO2. Well, increased O2 because of decreased CO2. And this shows ventilation and against work rate at sea level, shown here, at 5,800 meters, shown here, and 5,800 meters with oxygen. So again, as we talked about before, oxygen ventilation does not decrease back to the baseline level, suggesting that both hypercapnic and hypoxic responses are responsible for the increase in ventilation at altitude. So what's plotted here is a inspired PO2. It's decreasing this direction, so we're increasing altitude. This is sea level, and this is roughly top of Mount Everest. Minute ventilation is plotted up here. And what you can see is that as you increase in elevation, decrease PO2, minute ventilation increases to a point, and then it falls off at extreme altitude. The respiratory frequency increases as you increase altitude and then accelerates as you near summit of Mount Everest. And heart rate actually tends to fall slightly as you increase in elevation. So minute ventilation is markedly increased, increasing work of ventilatory muscles. Breathing is shallow and rapid, which increases exponentially at low PO2s. Lower barometric pressure decreases work of breathing slightly at altitude. That's because air is less dense, so turbulent airflow is faster. And increased minute ventilation at high altitude increases the proportion of cardiac output to ventilatory muscles, decreasing it to exercising muscles. So what's shown here is the proportion of cardiac output that goes to ventilatory muscles when exercising at sea level, about 5.5%, versus an elevation of 5,000 meters, which is, again, probably in the range of 16,000, 17,000 feet, which is 26%. So ventilatory muscle fatigue is certainly something that can limit ventilation in individuals with either very high work of breathing due to severe lung disease and or ventilatory muscle weakness, such as neuromuscular diseases. We don't usually think about ventilatory muscle fatigue limiting exercise in normal individuals, and indeed, in normal individuals exercising at sea level, so little of the cardiac output goes to ventilatory muscles that this would not happen. However, at high altitude, an increasing proportion, significantly increasing proportion of cardiac output must go to the ventilatory muscles in order for them to be able to perform the increased work of breathing required, so that ventilatory muscle fatigue could conceivably participate in a limitation of exercise at high altitude. So, exercise at altitude. Oxygen transport is diffusion limited. Pulmonary hypertension decreases cardiac output. Cardiac output per unit of oxygen consumption is similar to sea level, but maximal O2 consumption and cardiac output are both decreased at altitude. Increased minute ventilation increases work of breathing. Ventilatory muscles therefore require a higher proportion of cardiac output, and ventilatory muscle fatigue may precede exercising muscle fatigue at high altitude. These are factors important in increasing the maximal VO2 at extreme altitude. So this is a percent of increase in VO2. Barometric pressure, obviously a huge influence. Ventilation. Membrane diffusing capacity now is more of an obstacle. Base excess, not much. pH actually improves things slightly. Cardiac output and hemoglobin. So all of these things improve maximal O2 consumption. The increased pH actually decreases O2 delivery slightly. So any increase in alveolar O2 is the most beneficial adaptation or acclimatization to increase exercise performance. So if you want to successfully summit Mount Everest without supplemental oxygen, you need to do this. Therefore, increasing barometric pressure at altitude improves exercise performance. So attempt descent in good weather. We talked about the fact that barometric pressure is increased in summer and near the equator. A brisk hypoxic ventilatory response will decrease CO2 more, therefore increasing alveolar O2 more. You'd like a high diffusing capacity, and you'd like a high base excess to achieve the highest oxygen saturation in hemoglobin for the level of arterial PO2. Of all the physiologic changes in acclimatization to altitude, those increasing ventilation are the most important. Hypoxic and hypercapnic ventilatory responses both increase in the first few weeks of acute ascent to altitude. Hypoxic ventilatory response is most important to assure increased ventilation at high altitude, but the hypercapnic ventilatory response also increases, and they each contribute about half of the increase in minute ventilation at high altitude. Hypoxic ventilatory response correlates with the response after acclimatization to exercise. It predicts exercise ventilation at sea level and at altitude, and a high hypoxic ventilatory response protects arterial oxygen saturation during exercise at altitude, and it may predict adaptation and performance at extreme altitude. A high hypoxic ventilatory response may be necessary for climbers to extreme altitude without supplemental oxygen. Oxygen transport is diffusion limited at high altitude. Pulmonary hypertension decreases cardiac output, and cardiac output per O2 consumption is similar to sea level values, but maximal O2 consumption and cardiac output are both decreased at high altitude. Increased minute ventilation increases the work of breathing. Thus, ventilatory muscles require a higher proportion of cardiac output, and ventilatory muscle fatigue may precede exercising muscle fatigue. So next time we will continue our discussion of high altitude physiology in part 3. Thanks again to our producer-director, Dr. Catherine Lewinter, and thank you again for joining me for the great adventure, pediatric pulmonary physiology.